This is Sean McAllister for Anesthesia 4101, Assignment 2, Critical Thinking and Communication Submission. This particular case discussion took place at Mount St. Joseph's Hospital during an ENT surgical day, working with Dr. Justendra Naidu. Patient demographics: this is a 46-year-old female. She was in for image-guided functional endoscopic sinus surgery. She is morbidly obese with a BMI of 37 kilograms per meter squared. Her previous surgical history: she's had multiple sinus surgeries and is a negative for a history of malignant hyperthermia as well as post-op nausea, vomiting. Her past medical history: she is on OSA, or she has OSA and is compliant with her CPAP. She has insulin-dependent diabetes, hypertension, and upon further discussion seems to have poorly controlled asthma despite multiple puffer therapies, seeing several respirologists. However, no hospital admissions for her asthma. The patient's airway assessment and anatomy presented indicators of a difficult BMV and intubation. She is obese, she has a short neck and small mouth opening. She had a shortened thyromental distance of 2 centimeters. She had poor mandibular protrusion, although adequate cervical flexion and extension. As previously stated, she has had multiple sinus surgeries, so upon further investigation of previous anesthetic records, she has been intubatable previously with a McGrath X-blade, always done on first attempt. Returned to the room to present this information to Dr. Naidu. He went out and interviewed the patient and confirmed my findings. Given her history of being intubatable previously, he was happy to let me attempt intubation, but if there was any difficulties, I would back out and he would take over. Our induction was rather standard: fentanyl 150 mics, or 150, propofol 120 milligrams, and 40 milligrams of rocuronium. The patient was reasonably easy to bag mask. I didn't mess around, I just put an OPA in straight away. After about a minute and a half, when the patient giving time for the rocuronium to work, I attempted intubation with the McGrath VL X-blade. I was able to intubate the patient on first attempt with a size 7.5 ETT. She was anterior with a smaller glottic opening. Once the tube was through the cords, the cuff was inflated, and I began to manually ventilate to confirm placement with end-tidal CO2. However, there was minimal misting in the ETT, minimal chest rise, and no end-tidal CO2 after several breaths. Not long after, I noticed a obstructive pressure waveform pattern, and the feeling on the bag, the patient was quite tight to ventilate manually. After about what seemed like longer than 30 seconds, we started to get end-tidal waveform. Once the end-tidal was confirmed, I quickly placed the patient on the ventilator and quickly deepened her anesthetic with sevoflurane. Based on the patient's history and recognizing the obstructive waveform pattern while trying to manually ventilate, as well as the feeling of her compliance during manual ventilation, I communicated with Dr. Naidu on intubation that I was sure this was not esophageal intubation, that it was post-intubation bronchospasm, which was the reason for the delay in the end-tidal. He agreed. Unsurprisingly, initially, during mechanical ventilation, her P peaks were relatively high. But as the end-tidal sevoflurane rose towards about 1 Mac, the bronchospasm quickly subsided and the P peaks drifted down, and she was much easier to ventilate mechanically and manually. Of course, SEVO being a potent bronchodilator. Once the patient was settled on the ventilator, I had a discussion with Dr. Naidu about administering some Ventolin via the MDI adapter into the circuit to also further treat the bronchospasm, and he agreed it was a reasonable idea. As we were able to adequately ventilate and oxygenate the patient, we did not escalate therapy to acute asthma treatment. which could include deepening the SIVO to 4%, IV ketamine, Ventolin installation, Ventolin IV, Megsulf, and Solumedrol. Once the surgery began, the patient was saturating about 92% and was having to creep up on the FiO2s to 50, 60, 65%. There was a good SpO2 plus signal perfusion. I inspected ET, it had not migrated in or out. She was ventilating. I had a listen on auscultation. There was bilateral errantry, but it was notably decreased bilaterally. However, there was no bronchospasm. Upon further investigations, the pressure volume loop indicated she was quite underinflated. I presented this differential of derecruitment from the bronchospasm post-intubation in combination with the patient's body habitus for our current FiO2 requirements and pore saturations. Dr. Naidu again once agreed that this was likely the most reasonable differential. I performed a recruitment maneuver, 30 centimeters of water for 30 seconds, which the patient tolerated very well. Post-maneuver, I increased her PEEP from 8 to 12 centimeters of water. And within about 5 to 10 minutes, I was able to wean the FiO2 to 35%. From this point on, the case progressed without issue. The patient presented no further issues with oxygenation and ventilation. On extubation at the end of case, on extubation with emergence at the end of case, there was no issues with bronchospasm or increasing O2 requirements. This is my case presentation for critical thinking and communication submission. Thank you.